Hi, once again to everyone. So I'll take you quickly through intra-arterial chemotherapy and real-life challenges, no financial interests, and my affiliation. So intra-arterial chemotherapy, for postgraduate students, it's important. You might have to go back and read in detail. It's a direct intraocular delivery of chemotherapeutic agents via the ophthalmic artery. Now, how is it advantageous? The good things about intra-arterial chemotherapy and the positive side I'm going to speak is the advantages are increased drug concentration locally into the tumor. It's kind of sending the chemotherapeutic drugs directly to the tumor, minimal systemic absorption and systemic toxicity, and thereby avoids long-term systemic complications. So the drugs that we use are different from what we use in systemic intravenous chemotherapy. We use the VEC protocol, vincristine, etoposide, carboplatin, and these are different drugs. And why am I emphasizing this here? As a secondary intra-arterial chemotherapy where you have a chemoresistance to those drugs, you can always attempt an intra-arterial chemotherapy to salvage the eyes, all right? So thanks to Dr. Kaneko, who actually introduced this technique early 2000s and which was popularized by Dr. Abramson in United States of America as a targeted therapy for retinoblastoma. So intra-arterial chemotherapy focuses only on eye salvage and vision salvage. So that is the first challenge, all right? In country like India and less developed countries where we see advanced disease, where there is a high risk, clinical risk of systemic micrometastasis, probably intra-arterial chemotherapy is not a good choice, all right? Systemic intravenous chemotherapy helps in dealing with systemic micrometastasis, whereas this is very focal into the eye, all right? And to a certain extent, vision salvage. So that is a first challenge. Now, chemotherapy, we know systemic chemotherapy. When we talk about intra-arterial chemotherapy, when comparing to systemic chemotherapy, there can be ocular toxicity, all right? So these are the chemotherapeutic drugs which are going into the small vessels into the babies, which can cause ocular toxicity. It is expensive and, well, we need to have a cath lab and an experienced person, which of course the treatment technique has a long learning curve. We as ocular oncologists, we don't do this technique. We take help of an interventional neuroradiologist or a neurosurgeon to do this technique. And this is my interventional neuroradiologist.
Antithrombolytic.
So what we do is assess the situation, plan the drugs, whether it is single drug, double drug or triple drug therapy, and then the dosages. So the entire technique is done by a neurosurgeon. So this was a review article that we recently published in Indian Journal of Ophthalmology. In fact, this was my last page where, we spoke about the strength, the weakness, a SWOT analysis of intra-arterial chemotherapy. So, well, the weaknesses are, as I told you, it can have irreversible vision-threatening complications. It is expensive, and definitely we do have a lack of prospective randomized controlled trials regarding the real results of this. Now, there are threats. Again, as I told you, failure to identify the clinical high-risk features and then jumping into an intra-arterial chemotherapy is more deleterious for the patient rather than doing good. Now, with this intra-arterial chemotherapy, not much in India, with my experience in China, the parents knowing that there is something which can have better effect in controlling the tumor, they always want to go and, there is kind of a forcing of intra-arterial chemotherapy to the child trying to salvage the eye, where the parents doesn't understand that there is a very clear-cut indications for doing an intra-arterial chemotherapy. All right, and sometimes it also happens that interventional radiologist who's not into ocular oncology or who understands the principles of oncology, since there is a newer technique, they kind of go ahead and do these techniques. So these are the downfall of it. So this was a patient actually, one of the patients that I have treated who has already received intra-arterial chemotherapy, and this is how the child came to me. Well, whether they should go ahead with intra-arterial chemotherapy or not. MRI was not done in this child and intra-arterial chemotherapy was started. You can see there is a subtle proptosis already, and this is a group E where a proptosis has happened, and in fact she had an optic nerve extension, all right? And this is how histopathological globe looked like, and the patient received intra-arterial chemotherapy for eye salvage, which is very, very, very dangerous. So there are clear-cut indications. In my practice, I use it for unilateral intraocular retinoblastoma, group B to group D, bilateral RB if it is D and E, where there is a huge desperation to try to save one eye, irrespective of the visual potential, as a secondary therapy. Contraindications are advanced intraocular retinoblastoma, bilateral IAC if you want a vision salvage, because intraarterial chemotherapy has a downside. It can lead on to vascular occlusion, and the child can have massive choroidal atrophy, central retinal artery occlusion, and not have a vision in that eye. So if you want to save vision in one of the eye, never go for a bilateral IAC. And radiological evidence of optic nerve involvement. Now, group E retinoblastoma is a gray zone where some of the patients where parents really want to try for evaluation. If there is not much of radiological evidence of, sometimes we resort for group E retinoblastoma also. So these are beautiful results of intraarterial chemotherapy, and especially in group D eyes, it's extremely good. Here you see it. There is vitreous seeds persisting. With intravitreal chemotherapy, the entire thing has regressed. A lesion which is very far in the periphery, 2 sessions of intraarterial chemotherapy, it has regressed. And well, as you can see, peripheral tumor, the same eye, where even the macula, the vision salvage is also done. Not always. It is also associated with bad vision threatening complications also, choroidal atrophy, vascular thrombosis, as I've mentioned, hyperemia, ptosis. These are common and it resolves. Well, alopecia, does it happen only with systemic chemotherapy? I do have few patients in my series where even alopecia has happened unilaterally in the area of intraarterial chemotherapy. Now this is boom. Well, this intraarterial chemotherapy where has been given to this eyes has complete choroidal atrophy over here. So sometimes it can happen, and because the drugs can cause endothelitis and closure of the vessels. Well, severe choroidal atrophy. In fact, this is a very potential, visually potential eye. And you cannot always predict, although you want to do good for the patient, so you have to be very choosy. And this is how the OCT looks like in this patient. Choroidal hemorrhage, central retinal artery occlusion. So sorry for this, because there is a change from Mac to Windows over here. So group D tumors, yes, it is very helpful, where you can see this is actually 94 and 85, and this is systemic chemotherapy with 47% of vision salvage. So group D, definitely there is a jump in the outcome, like salvage of the eye. So group E eyes, we did evaluate this in our review, and we found there is hardly any benefit of giving intraarterial chemotherapy in group E eyes. So well, possibly not attempted. Now, the most important thing in our practice in India is, unfortunately, retinoblastoma is seen in the low socioeconomic group. I'm sure everyone agrees to it. And well, I hardly give intraarterial chemotherapy. Most of the patients are very poor and they cannot afford it. A systemic intravenous chemotherapy for 6 cycles would cost a patient 60 to 80,000, completing the entire treatment. But in an intraarterial chemotherapy, the first session, one session would cost around 1.2 lakhs to 1.5 lakhs, and they need a minimum of 3 to 4 sessions. So most of these patients may not be able to afford. There are foundations which takes care of these patients where they're not able to afford such a high cost for the treatment, where Dr. Vikas has shown that systemic chemotherapy definitely gives a very excellent outcome as well. So once we have the public hospitals taking over and having the facility in a public hospital with intraarterial chemotherapy and the catheter charge. So the catheter, we need very small catheters in babies, and catheter actually is costly. It is around 75,000 to 80,000, that itself. With the charges, admission charges, GA charges, everything goes up. So well, if all these things comes down in the future, probably we will be able to give more intraarterial chemotherapy to these patients. Yeah. So these are the challenges with IAC. Although IAC is one of my favorite treatment modality in retinoblastoma, and most of my patients in China receives IAC, but I would say 98% of my Indian patients receive systemic chemotherapy, mainly because of the financial constraints. We have experts in India. The doctors have a very, they are experts in the technique, but well, finance is definitely a major issue. Thank you so much.